Welcome to our journal club for today, September 9th, 2021. Our presenter is Dr. Chesika Crump. She's going to speak to us about a paper entitled Effects of Olanzapine Combined with Samidorphan on Weight Gain in Schizophrenia, a 24-week phase 3 study. Thank you, and Dr. Crump, take it away.
All right, thank you guys for joining me today. Hope you had time to read or at least review the article. If not, we'll be going into it in pretty detail, so no worries. So as disclosures, myself, none, the authors of the study are sponsored by Alkermes, which is the pharmaceutical company that produced this drug, and they were advisors to the company as well as stockholders. So before we really get started, let's get in a little bit into the background. So the overall main objective of this was to see if by adding the Samidorphan to olanzapine, it could mitigate some of the weight gain associated with olanzapine. And the reason why this is clinically significant is because we all know olanzapine is an effective antipsychotic, but associated with significant weight gain and other metabolic abnormalities, which for a lot of people is a reason to discontinue and limits the effectiveness and the use of the agent. So if this new strategy of adding Samidorphan can mitigate some of that, it can increase the use of this agent and can be pretty relevant to people who are stable on olanzapine. But in order to really get into the significance of that, I think it's important that we just review olanzapine and some of its properties. So this is olanzapine, also known as Zyprexa, second generation atypical antipsychotic. Here's its structure. And this is just some basic pharmacology, elimination, as you can see, for oral and short-acting IM, about a mean of 30 hours, longer for the long-acting and intramuscular injection, mostly metabolized through the liver and through cytochrome P450, and about 40% removed during first-pass metabolism. Most of it, 93% bound to plasma proteins, and time to peak for oral around 6 hours, and IM short-acting about 15 to 45 minutes. The mechanism of action in schizophrenia as far as olanzapine is unclear, but we have done a lot of studies on how it acts on certain receptors. So here's just a general picture of the different receptors that olanzapine acts on. The most prominent ones being it has potent antagonism at the serotonin 2A, 2C, as well as dopamine, histamine, and alpha-adrenergic receptors. And we all know from the dopamine theory of schizophrenia that part of the serotonin, the antagonism there can lead to prevention of some of the negative symptoms of schizophrenia, such as anhedonia, flat affect, poor attention, while antagonism at dopamine decreases more of the positive symptoms, such as hallucinations, delusions, disorganized speech. Moderate antagonism at muscarinic receptors and weak binding at GABA and beta adrenergic. And if we know what the receptors do, then we can know how antagonism at those receptors can lead to some of the side effects that are commonly associated with olanzapine. So with that muscarinic antagonism, we get the anticholinergic symptoms, dry mouth, blurred vision, dry eyes, constipation, etc. At histamine, we get sedation. And alpha-1 adrenergic, we get orthostatic hypotension. And then the one that's going to be the main focus for today is the metabolic syndrome and those symptoms, which is antagonism at the serotonin 2A, the 2C, D2, and T3 receptor, as well as histamine and muscarinic 3 receptors. So this is a table that we've all probably seen or used many times before, and this is comparing the second and first generation antipsychotics and their affinity for different receptors. I have olanzapine kind of highlighted and boxed out in red. And as you can see, it's measured in BKI, which is basically just a review. It's the nanomolar quantity of the drug needed to block 50% of the receptors. So the lower the number, the stronger the receptor affinity. And you can see what that looks like for D2 and the rest of the serotonin receptors listed. So antipsychotics and metabolic syndrome. When a lot of these antipsychotics came out, while we knew from studies they were associated with weight gain and significant metabolic abnormalities, we really didn't know why that was happening. However, in the recent years, there's been a lot of research on proposed mechanisms of how these antipsychotics, specifically those like olanzapine, clozapine, and even how they'll lead to metabolic syndrome. One of them is that the antipsychotics actually affect hunger and anxiety, leading to increased appetite and weight gain. There's research on how blockage of HTR2C can lead to hyperphagia and obesity. There's research on how dysregulation of the leptin and ghrelin hormones responsible for appetite suppression and stimulation can also play a role. There's even research on how a lot of antipsychotics change our preference, increasing our preference for fattening foods. But the one that I was doing some research on that I found very interesting was how antipsychotics cause dysregulation of insulin and glucagon secretion. So we all know that dopamine and norepinephrine and other neurotransmitters act in the central nervous system, but new research has also shown that they act and have a role in pancreas and glucose metabolism, actually acting as peripheral modulators of that secretion. And so that's kind of not a novel pathway, but more research on a pathway that could explain some of these symptoms that we see with the olanzapine. So as far as kind of the proposed mechanism of action for how antipsychotics impair glucose, we kind of have to go over the basics. So as we all know, the pancreas, we have in the isolates, we have the alpha cell and the beta cell, alpha secreting glucagon, beta cell secreting insulin. And on those, they each have different receptors that when stimulated lead to different effects. So we're all familiar with the D2 and D3 dopamine receptors on each of these cells that are at high affinity, and they have an inhibitory action. So when dopamine stimulates these, they get an inhibition of glucagon and insulin. However, there are other receptors on these cells. For the alpha cell, there's the beta adrenergic receptors that, when stimulated by dopamine, actually lead to an increase in glucagon secretion. And on the beta cells, there's the alpha adrenergic receptors that, when stimulated, kind of add to the inhibition of insulin. So how do antipsychotics play into this kind of proposed pathway? So we have our antipsychotic drugs such as olanzapine. They act at the D2 and D3 receptors. And what they do is they end up blocking the inhibitory effects of those receptors. And in the beta cell, which is responsible for secreting insulin, you get a disinhibition of insulin, increases insulin in the body, leads to desensitization of insulin-sensitive organs, and ultimately leads to insulin resistance. While when you have the disinhibition of glucagon secretion in the alpha cells, you get increased glucagon, you get increased glucose hyperglycemia, which overall exacerbates insulin resistance and leads to a lot of the symptoms that we see with metabolic syndrome. And I thought this was very interesting because it really put into perspective, have a pathway explain why olanzapine, clozapine, and other antipsychotics increase risk of metabolic syndrome. And because second generation antipsychotics are so well known for their metabolic effects, there has been a monitoring protocol proposed by Diabetes Association and other agencies on how to effectively monitor. So if you have a patient on this at baseline, you want to ask about personal family history of any diabetes or cardiovascular diseases. Of course, want to get baseline weight, BMI, weight circumference, blood pressure, glucose, and lipid profile. And then in different increments of time, you want to measure that just to monitor for any metabolic syndrome. And of course, we all know that if you do see signs of that, then the options are either to decrease the dose or to switch to a more weight neutral antipsychotic such as Abilify. So that's information on olanzapine, and this is Samidorphan. It is basically a mute opioid antagonist, has some partial effect at the kappa and delta. It has a very high affinity. And the drug that kind of in focus today is olanzapine and Samidorphan, or Lynbalvi. It's been FDA approved of this year in about May for treating of schizophrenia or bipolar, and that's a treatment, acute treatment of manic or mixed episodes as monotherapy or adjunct to mood stabilizer, or as monotherapy for maintenance. Only now it's still just an oral form. These are the dosages and the The first number you see is the dose of the olanzapine, and then the second number you see is the Samidorphan, mostly metabolized through the liver. And the mechanism right now is pretty unclear, but we know that we're very well aware of what olanzapine and its effects on the receptors. And it's been proposed that the way Samidorphan behaves is that it attenuates some of the olanzapine associated changes in fat mass via blockade of adipose glucose uptake, or by preventing olanzapine-induced insulin resistance through some unclear mechanisms at this time. So let's get right into looking more at this study. Starting with the methods. So first we have to look at the inclusion criteria. So any patients 18 through 55 who meet criteria for schizophrenia, outpatient, only looking at people with 18 to 30 BMI and a stable body weight. This is the exclusion criteria. As you can see, the list is a lot longer, making it a bit more restrictive. Some things to note out here is no treatment of resistant schizophrenia, can't be naive to antipsychotics, no active substance use disorder or unstable medical condition, which could compromise patient safety or data collection. And as far as the Samidorphan, don't want any patient who has used an opioid agonist within the last 14 days, so this could precipitate withdrawal symptoms. And if there's any anticipated need of opioid treatment in the study, then these patients could not participate. This is just a table just of the overall study design and kind of the treatments used. Of course, once you have your group of patients that meet that inclusion and exclusion criteria, they were randomized in a 1-to-1 ratio into the treatment group of olanzapine and Samidorphan at these doses versus kind of the placebo or olanzapine group. They were in the study for about 24 weeks. And then after data, they were either given the choice to do a safety follow-up for about 4 weeks or to continue in a longer safety study. So just to review for people who don't know, kind of phase 3, when we look at clinical trials, is evaluating how a new medication works in comparison to an existing medication for the same condition. With these two groups of patients, any other psychotropic drugs they were on were cross-tapered onto either two of the study drugs, and that cross-tapering happened within the first 4 weeks of the study, and no other changes could be made after that. And while no other psychotropic drugs could be used in these patients during the study, there were some exceptions of some medications they could use. Some common ones were beta blockers, antihistamines, benzodiazepines, and anticholinergics, mostly used to treat any EPS symptoms caused by olanzapine. So these are different measurements that they used for the study, the most important being body weight and waist circumference, since we are looking at weight gain. Some other ones to look at is they also looked at adverse events and extrapyramidal symptoms using assessments we're familiar with, such as AIMS and the Columbia Suicide Severity Rating Scale. To look at efficacy, they looked at the PANSS, or Positive and Negative Syndrome Scale, used to measure symptom severity with schizophrenia, and the CGI Severity Scale, or the Clinical Global Impression Severity Scale, using assessment for the clinician to look at the patient's functioning before and after initiating the study medication. And then another important one is the metabolic lab parameters such as triglycerides, cholesterol, and glucose. So the endpoints that they had two co-primary endpoints, 1% change from baseline in body weight, and then proportion of patients with greater than 10% weight gain from baseline, and the proportion of patients with greater than 7% weight gain from baseline. The reason that these thresholds were chosen, the greater than 10% and 7%, is because they were clinically significant for research looking at weight gain and the interaction with psychiatric treatment. So now that we reviewed kind of the endpoints and measurements, we get more into, once they got those measurements, what data analysis that they used. So starting with the sample size. So initially they had a target size of 200. However, halfway through the study, they did an interim analysis just to see where they were going with their data. and the power was low after doing that re-estimation, so they increased the target size to 540. And just a brief aside, an interim analysis is just kind of an assessment halfway through an ongoing study where it's unblinded and using an independent researcher who looks at the data and basically determines, is it possible to or reasonable to continue with some modifications to the study, or is it pretty futile and we need to stop the study? Usually with clinical trials, that usually the second option happens if it's found out that the drug that they're studying is actually more harmful to the patients than they realized. And I just found it a very interesting way to analyze data, clinical trials, because it's really a way for them to optimize their operations. And what would this presentation be without reviewing some basic statistics? Of course, we've probably all seen that. It's on step 2 and step 3, looking at power, type 1 and type 2 errors. So the null hypothesis kind of this study was, no significant difference between body weight or waist circumference between the olanzapine Samidorphan group and the olanzapine group. While the alternate hypothesis would be there was a significant difference in body weight and weight circumference, with the researchers kind of hypothesizing that the treatment group, the olanzapine Samidorphan, would have less weight gain. So with the analysis of the endpoints for the first primary endpoint, they used an ANCOVA, or analysis of covariance, which is basically just testing the main interaction of main variables on the dependent against a continuous dependent variable, and then controlling for any covariance. So the main factors they were looking at were treatment agent race, and covariance were the baseline body weight. Other endpoints were measured using the logistic regression model. And then and this is the analysis of other measurements that they were looking at. So just to round out kind of our review statistics, it's important to look at odds ratio, which is the odds of an event occurring in exposed group, the olanzapine Samidorphan, versus the odds of the event occurring in the non-exposed group, or the olanzapine group. And of course, if it's greater than 1, then as you can see, it's greater the odds will happen in the exposed group, less than 1, more likely happening, the events happening less than the exposed group, with 1 being that there's no difference. And this is just a general overview of the confidence interval and p values. Just something to note for confidence interval, if it contains 1, then the calculate odds ratio is not considered statistically significant. And another thing that you will see in the results is the number needed to treat, or the number of patients you need to treat to prevent 1 additional bad outcome. And these are the formulations and kind of the formulas that I know a lot of people have probably already seen. So now that we kind of reviewed the data analysis and kind of the methods and assessments, let's look into the results that they got. This is just a table on just baseline characteristics of participants between the treatment group and the placebo group. Overall, they got about 561 patients. About 64% of the patients completed the treatment. Some common reasons for discontinuation were adverse events, loss to follow-up, or withdrawal. And they did their best to control for drug exposure and other medications patients were on, and found that they were pretty similar between the groups, and there were no real significant changes there. This is just kind of more of a table explaining kind of the breakdown of each of the groups being studied, and kind of the reasons for any discontinued treatment within both. So the first figure we look at is the first co-primary endpoint, which is the change from baseline in body weight from the beginning of the study to the end of the 24 weeks. As you can clearly see, there was less of a change in the olanzapine Samidorphan group of 4.21%, and then olanzapine was 6.59%, and that difference was statistically significant. Overall, right here in this table, just showing the cumulative frequency of distribution of the percent change between the two groups. It was very interesting to note that at the beginning of the study, there were similar changes between two groups, but while the olanzapine, there continued to be more changes in weight. The olanzapine samidorphan group kind of tapered and plateaued off at a certain point. This is a table looking at kind of the proportions, and this was looking at the second co-primary endpoint and the secondary endpoint. Again, olanzapine samidorphan group is a lot less than the olanzapine group, and that is statistically significant. The odds ratio that they calculated was 0.5, which meaning that the odds of weight gain in the olanzapine samidorphan group was half of that of the olanzapine group, which was also pretty significant. So this was looking at the waist circumference, which was one of the, with in addition to body weight, was one of the pretty major measurements that they were looking at. Again, olanzapine samidorphan has olanzapine being in that there's less weight gain, and that difference in between the two groups was significant. They also looked at proportion with a waist circumference increase of 5 centimeters, which is a finding in studies associated with increased mortality. And the proportion for the olanzapine samidorphan group was 26.8%. The olanzapine group was 43.2%, and that difference was 17.1 with an odds ratio of 0.47 and confidence interval of negative 26.3 to negative 7.8. And it was statistically significant. One thing that was really a shock in this study is that when looking at the metabolic parameters such as triglycerides or cholesterol, there was really no statistically significant changes between the groups. Now, I do have highlighted in red the difference in the triglycerides, because even though it wasn't significant, it did show some of the largest changes between the metabolic parameters, but that was very interesting that between the groups, they didn't really see anything. And then this is a review of the adverse events, one of the other measures that they were looking at, and I have in here kind of blocked off the proportion between those affected in the olanzapine samidorphan group and the olanzapine group. One thing that I thought was interesting is that when you look at the adverse events in greater than 5% of the patients, when it came to somnolence, there was actually a percentage more in the combined olanzapine samidorphan group than the olanzapine group, and also there was greater in that group for dry mouth as well. But when it came to weight increase and increased appetite, definitely there was a less proportion in the olanzapine samidorphan group. With efficacy and safety profile, there was really no clinically meaningful changes observed. Also no clinically meaningful changes observed with vital signs, EKG results, or either the AIM score. This is looking at the PAN scoring baseline. As you can see, pretty similar between the two groups. And then at the end of the 24 weeks, again, pretty similar, but no, as you can see from the confidence interval, crosses 1, so not clinically significant. You guys didn't have this, but this was in the online supplement, just showing a graph of looking at the clinical global impression severity scale. Again, just showing that there's no statistically significant differences between the two groups when it came to that assessment. So now that we've gone over everything, it's time to look at the discussion. And overall, the summary of the findings is there was significantly less weight gain with the olanzapine samidorphan group versus olanzapine, and there were also smaller increases in waist circumference between those groups. What was, again, pretty interesting is that there were no significant differences between the groups on metabolic lab parameters, EKG, measures of efficacy such as PANS or CGI, or in the safety profile as far as adverse events. So as far as those measurements, the drugs were pretty much the same. And while the study did well with having a large sample size and having very frequent analyses, there are limitations. 40% of the patients discontinued the study, and they did their best to remedy this by using a multiple imputation approach to handling the missing data as far as the statistics. Another thing that was pretty significant is as far as the fasting status, they just did it based on self-report for the patients and didn't actually confirm their fasting status, which I feel like really would have affected what we saw with the metabolic parameters. And then the very restrictive criteria that they had for inclusion and exclusion. One thing I really focused on is that the inclusion is that the BMI had to be between 18 and 30. So is it possible that the people they got in their study were people that were resistant to weight changes and metabolic dysregulation to begin with, which could have affected the results in the end? And then it was only people between the ages of 18 through 55. So really, we don't really know how the drugs would do in the geriatric population. And then the period was only of 6 months. While in other studies looking at antipsychotics had a similar timeline, it would be interesting to see like how would the olanzapine Samidorphan fare in a longer period of time. So what is the clinical implication of this? While overall there was a modest effect, it was still significant on weight gain with less weight gain compared to olanzapine alone. And this is can be pretty significant and relevant to us as psychiatrists because it could prove to be a beneficial medication for patients with schizophrenia who do well with olanzapine, but who had the undesirable weight gain and metabolic abnormalities. But with any benefits, we have to really look and consider like how much of advance is this medication. We already have a lot of studies looking at how a lot of people who use olanzapine in their patients to kind of mitigate the weight gain and metabolic effects, they add on metformin, which is proven to be very beneficial. And again, if olanzapine is an issue, then some psychiatrists just switch to a more weight neutral antipsychotic, which can work just as well. And then with this being a new medication, of course, it's going to cost a lot more. It's pretty restrictive on the dosages that you can do for patients. So a lot of psychiatrists are even wondering if this even is going to be very useful for them in their practice. So as far as the future of this drug, I think there's going to have to be some future studies to really look at not only how effective it is versus other medications, but also in the long term, how useful is it? I would be interesting to see how olanzapine Samidorphan compared to other atypical antipsychotics as far as efficacy and metabolic syndrome. Also be very interesting to see it versus olanzapine metformin, which is kind of what a lot of psychiatrists use when they have patients who suffer from the weight gain. And then it'll also be interesting to see how this would fare in geriatric and pediatric populations. And there, of course, I'm sure there's a lot of other studies that could be done in the future to really look more at this drug. So that is the end of my presentation. Any thoughts or comments or feedback on any of it? I'd be happy to hear your thoughts. And these are just my references that I've used.
Hey, Chesika.
Yes.
I thought was a really well done presentation. I've been interested in this drug recently because I'm actually we may be starting on a patient soon in the outpatient clinic and bipolar clinic because she's responded well to Zyprexa, but she's had a lot of weight gain issues in the past, and this might be a good option for her. I do find it kind of interesting. Like this is more of a comment than a question, but these combination pills we have out there, like a lot of them, obviously a lot of them are very pricey. And when really you're not doing anything new, you're just combining two medications that work well synergistically. So one thing, maybe some attendings can also comment on this, like if a family member is providing the medications, if they're monitoring medications and giving the medications to a patient with schizophrenia or bipolar, why can't you just prescribe both olanzapine and samidorphan separately? The only issue is combination pills make the medication regimen simpler. And for patients who are doing their medications themselves, they're disorganized, they forget, obviously there's risk they're not going to take it. But if a family member is monitoring the medications, why not just prescribe them separately and save several $100s?
Any Deans or any comments on Dr. Oliva's comment?
I mean, to build off that, can you mute that? To build off that, it just seems like a giant waste of money when we have metformin, which probably has additional benefits as well, until we can prove that it's better than metformin. I don't really see a huge reason to use it.
And that's something that
Well, just to add to that,
continue.
just to add to that, I wonder if you could use naltrexone. I don't know a whole lot about Samidorphan, but I know Dr. Wong tries to use the combination of dextromethorphan and quinidine instead of, I believe it's Nudexa, just for simple cost purposes. Chesika, do you know if there's any literature out there about naltrexone substituting for the Samidorphan or Samidorphan?
I don't remember coming across that, but I would be very interested to see if that has been used, since naltrexone is pretty common.
There's been a few studies with naltrexone. I mean, it shows similar things to what this study showed. I mean, works very similarly, so you would expect pretty much the same thing. But I mean, when you really look at the results from this, at least over the 24 weeks, there was no change in the metabolic effect. So who really cares about weight gain? If you're really schizophrenic, you're probably not going to care if I'm going to increase my weight by 12 pounds versus 8 pounds. So, I mean, I think right now, without further studies and without this going far, like longer term to see if it actually helps metabolic effects, I think it's a non-issue, non-drug.
And when I talked to some other attendees, when I was looking at this article on my VA rotation, a lot of the attendees and had the same kind of comment. It's like, how useful really is this? It's like a lot of them just use metformin, or they just switch to something else besides Zyprexa. So I thought that was pretty interesting.
And going back to the patient I'm starting it on, it's a very specific patient who's already been on a lot of medications. She's failed a lot of other medications, and she's already on metformin as well. So we're just trying to do something else on top of it to help her. She has a very unique circumstance with this medication.
That's an interesting point you bring up, because one thing that I saw that was kind of an issue is that there's such a restricted combination of each of, olanzapine and samidorphan, and if you can have a little bit more flexibility with your dosages if you had, olanzapine and then just had a separate samidorphan pill.
You could always have the patient with concomitant opioid use disorder along with schizophrenia that, it could be used as an opiate treatment as well.
That's very true. Very good comment right there.
That was really good, Chesika. It's a really interesting topic. I haven't had a chance to read the article, but did they comment at all about the study population? It looks like it was mostly Black men, right? Pretty heavily tilted towards that.
I did notice that as well. Yeah, but yeah, that is very interesting. A lot of it was Black males. I would have to look more in where exactly they got a lot of their population, but I think that might have been a bit more in the online supplement, which sadly I did not send out to you guys. But if you are interested, it has a lot more kind of background information on this study on why they did certain things, as well as some more graphs on some of the pretty non-significant results. But if you're interested, I could send it to you guys.
Dr. Crump, have you checked the question and answer portion of the app?
Yes, let me check here.
If there's anything there you'd want to respond to.
Okay. Okay, so this is from Catherine. Going off what you said regarding the restrictive inclusion criteria, while this combo appears to have good clinical efficacy for relatively uncomplicated patient, those with concurrent substance use issues, particularly if they're on MAT like Suboxone, wouldn't be a great choice. On another topic, my question is whether there was any specific information stratifying weight loss in the treatment group based on pre-study BMI, and there was a difference between patients with higher BMIs versus lower. That's a very good point with the substance use. Like, yeah, you couldn't use this with people with opioid use disorder. And then as far as the stratifying weight loss, to be honest, I'm not sure, but that's something I can definitely look at a little bit further. Maybe something that's mentioned in the online supplement or in some past studies that they did. That is very interesting. I would like to see that too. But yeah, ultimately, I don't know. Thank you. Any other questions? Let me look at here. Here it's a question, have they done any studies using variables like A1, HbA1c or LD that have shown effective results? I think A1C and LD were used in this study as a measurement. Is that what you're asking? I'm just trying to make sure I'm answering the question correctly. Are you asking if they measured those in this study? And then the other question is, how did they factor in tobacco use for inclusion and exclusion for the study? I think, actually, that is a good question. As far as I'm concerned, like anything like opiate or benzo or use disorder, all of the use disorders except for cannabis use disorder, those people were excluded. But I did not see anything about tobacco use. I assumed that was excluded as well, but I'm not quite sure and would have to look back on that. But that is a good question.
Yeah, I think that's a great question because it points out the fact that if the naltrexone or samidorphan, whatever the opiate antagonist, if it's got any effect on the patient smoking, then you could potentially just be seeing the effect of higher doses of olanzapine or higher effective doses of olanzapine in the group that has the opiate antagonist on board.
Yeah. Yeah, that's a good question. I'll have to look back at that to see what exactly that included. And again, there's a lot of things mentioned in the online supplement that sadly I did not send with you guys, but if you're interested, I could send that back to you. And then as far as back to this person's question, have they done any studies using variables like A1C that have shown effective results? For this drug, the Olanzapine Samidorphan, I haven't seen anything. Then any other questions?
Chesika, you had a table about the monitoring.
Yes.
Kind of a reminder of like how little we do that.
Yeah.
And how we really should be. I mean, it's in our defense, it's hard right now with all the telepsych appointments, but I mean, yeah. I know seeing that chart reminded me of how to be more vigilant.
Yeah, and that actually was when I found that with the Diabetes Association, there were other studies by pharmacists talking about how we don't do that. We don't do that monitoring in our patients who are on these drugs, and how it's kind of unfortunate because we can't catch these symptoms a lot sooner.
Thank you for the presentation, Dr. Crump. We'll wind it up then. You'll have a nice day.
All right, thank you all.